ثاني. دكتور توني تنوري رئيس IMS هيحكي لنا عن how to develop MIS practice minimal invasive surgery.
بدي اعتذر مسبقا انه ما رح اقدر اتكلم بالعربي. انا دارس طب كله بالفرنسي وبالانجليزي، بقى سامحوني. صار لي انا 22 سنه بمارس طب المينيملي انفيزيف، يعني من خلال ثقوب صغيره. ماشي الحال. رح بحب احكي عن الاكسبيرينس تبعولي، خبرتي، وين بنلاقي انه في سقف لازم نتخطاه وكيف تتخطاه، لانه اليوم كلنا بنعرف المينيمال انفيزيف بالشعار كثير حلو، عذاب اقل، وجع اقل، نزيف اقل، اتسترا اتسترا، بينما لازم بركي بقدمها من هون.
واذا بدك تقلب من هون قلب من هون، وهي مؤشر. تمام،
اوكي.
هذا مؤشر بدك توصل.
والتقليب وينه؟ لا خليني اقلب هون، لكن ايهو. اوكي. من حيث المبدا كلنا بنفضل الجراحات المينيمال انفيزيف بشرط انه تكون فعاله وبشرط انه تكون سيف، يعني تكون امنه. لا اخبركم عن اكسبيرينس تبعولي انا over the last 20 years. Oh, sorry. These are my disclosures. كل البراغي والمسامير والcages that you'll see in the presentation, they are my design, my inventions, so take that into account. The problems of minimally invasive surgery كلنا بنعرفها. Less muscle damage, less denervation, muscle hospitalization and time out of work. The question is how to break your own ceiling. When you get into a certain level in your practice, how to break that, go into the next level up. So adopting new technology factors to consider. So first of all, you have to consider every technology taken is what is the learning curve? Is it difficult learning curve or not difficult? What is the application scope? How much is going to apply? Is it going to apply to 1% of your patients, one case per year, or it's going to be a daily event for you? So you need to know how much you spend time to learn it. And plus the cost of the technology, particularly in this part of the world, the cost is a problem. For the patient and for the system. If you look about, in any technology in the spine, you always think about access and think about mechanics. The surgeon who forget these two principles, they fail. And every technology who did not think of these principles failed. So all these technologies fail because they're totally against any logic in terms of mechanics or in terms about respect of the anatomy. I hope I do not offend anybody who does use some of these designs, but this is my position and I appreciate that. There are some other technologies which are worth considering. I don't use them now, but I think that I'm not totally against, if you spend enough time to do them and learn them. So adopting new technology is a must. يعني ما تفكروني أنا إنسان متحجر. So you need to adopt a new technology. But first of all, you have to understand anatomy very well. So there is a new wave of MIS surgeons that they don't think that they need to learn the anatomy because they're not opening the back or the spine. And they don't need to learn mechanics. And that's misunderstanding. And also, it should not be a marketing pitch. You don't want to use this as a marketing, look at me, I do disc replacement, nobody else in the country does disc replacement. Well, guess what? Disc replacement does not work, particularly in the lumbar spine. Yes, that's why maybe you are the only one using it. So that's you need to take that into account. The anatomy is very complex. So you need to anatomy. I tell my residents, my fellows, the spine should be like you walking in the dark in your own home, in your own bedroom, like when the light off. You know exactly where the bed and where the الكنباية حقهم, where's the light. And you can walk blindly, and you can find your way into the bathroom, particularly when you get over 50. So the anatomy, you should be able to know the anatomy, everything what it is. And that's the only way you could do safe MIS surgery. And that's the only way you could be audacious, يعني إنسان جريء be it minimally invasive. Only if you know the anatomy. But also at the same time, you need to address mechanics. The forces across the spine are extremely difficult, extremely hard to replicate. So if you don't marry these two principles, you're gonna fail as MIS surgeons. So it's better to do open surgery. We all know these patients. We all know grandmothers and grandfather and the way they walk. I'm not going to spend a lot of time about the principles, but there's one principle why spine balancing is important, is energy, is how much everything in life is designed to preserve energy, not consume energy. If I'm balanced, I don't need energy to keep me straight. If I'm bending to the side, I'm going to need a lot of energy to keep me straight. And that's the number one reason for failures for these surgeries, so keep that into account. So, in my experience, you start, like probably a lot of you start minimally invasive discectomies through a small tube, and we all know about it. And it worked, for one level. And then you start doing like, a T-lift and MIS T-lifts, and for one level or two level fusions, and it worked. You go through the learning curve and stuff like that. And this is my own practice, my own experience. And this is a patient with a 3-level surgery, and I did the surgery, 3-level fusion here. And this is the post-op X-rays. This is a patient here. She's happy. She's excited after surgery, 2 weeks after surgery, but I'm not happy because I know I did not help that patient. I know I did not serve the patient to the level that maybe another open spine surgeon in my hospital or in my town could have helped her. Why? Because she's not balanced. The patient is not balanced. But she's happy she's alive. She's happy she's not paralyzed. But I know down the line she's going to pay the price for that. So the question is, if MIS, minimally invasive surgery, is worth it for small cases, I just showed you, discectomy, 1-level fusion, et cetera, but it should be ideal for much more complex pathology, few tumors and so on. So when evaluating two technologies, technology 1 and technology 2, or technique 1, technique 2, if the delta, the difference between them, if it's not much, there's no point doing it. But the more the delta is, the more then you pursue the technique 2. Of course, you don't want to be in technique 1, obviously, right? So, but the MIS surgery, this is the open surgery. I'm talking about spine surgeon, right? Not knees, hips, and shoulder, and whatever. So in open surgery, you start not in the number of years, but in the number of levels fused. 1 level, 2 levels, 5 levels, 6 level, 12 levels spine. And they are repetition of the same procedure. Like 12 levels is not bigger surgery, it's longer surgery. You're doing 12 times the stuff you do for 1-level fusion. But for MIS, it's different. MIS, you start going 1 level, 2 level, and then you learn the 3-year learning curve, and then you get to the 3 level, and things start going downhill, going down. Your results are less good, just like I showed you that patient. So I took myself and I said, what can go wrong when you cross that barrier 3 levels and up? And I realized that, yes, you have to answer L5S1. L5S1 is the most important disc in your back because that gives you that pitch. This is what gives you the balance of the spine. That's one L4, 5. The sagittal balance, how to do that, how to do fusions multiple levels, how to do iliac fixations as a foundation for your building, right? Every building has to have a strong foundation. And deformity correction, how to correct these deformities. Because it doesn't help if you do MIS surgery on a deformity patient, but the deformity is not corrected. It's just simply to do MIS surgery. So I guarantee you, the first thing you learn, my fellow and my resident, they learn from the first week how to put screws from T1 to the pelvis percutaneously with no problem. That's the easiest part in MIS. But the more difficult part is to do the correction of deformities or do the rest of the procedures. So how to achieve sagittal balance, meaning this way, how to achieve fusion, and how to achieve decompression. And if you look here, so I can guarantee you that if you want to do MIS, you're going to go always into this discus space. So that means you have to do the interbody devices, and that means cages. If you don't do that, I guarantee you it's not going to work for multiple pathology, difficult pathology. Anterior approaches are we all love anterior approaches if we get you there safely. But the problem is you have a lot of stuff in your way. You have the bowels, you have the vessels, you have the ureter and all these things. So here's my technique that I'm proposing. This is the other technique I developed over the years. It's called ATP, anterior to the psoas. Some other people call it OLIF procedure. So you go just very low tech. This is a psoas muscle. I don't know what's called in Arabic. And go down to the spine. And this is how you do. You get down to easy to the L5, S1, L4, 5. Through one incision, 5 centimeter incision, you could do T12 to the S1 through that same incision. So this is a patient with degenerative kyphoscoliosis, very rigid. You can see that does not move at all. And this is the MRI here. It's quite bad. And this is a patient here. You do that all through that 5 centimeter incision from the side. We put all the cages on the side, and we put the screws percutaneously from the back. And this is the correction of the sagittal balance of that patient. This is a different patient. She's the mother of my secretary, actually. And then she has the same kind of similar scenario. And this is the MRI here. This is the X-rays. You see full correction of deformity on the both AP and lateral views. And that's her balance here. She's nicely balanced spine. So how disruptive is MIS surgery? MIS is not the same open surgery through smaller incision. It's a whole different procedure because you do things differently. Not how, but sometimes you treat the pathology differently. I'll show you some examples. So this is a patient who has adjacent segment disease, here. So, the patient had the prior L4 to S1 fusion, L4 to S1. The patient developed L3-4 adjacent segment disease. Instead of me going from the back, taking all the hardware out, extending up, you go from the side, you just extend the fusion up one level from the front. So you treat the patient totally differently than open surgery. This is a patient with 2-level adjacent segment disease. So you could do the 2 levels above, and you could do even more than that. This is a patient who had a prior surgery before, and she was traveled from the Middle East to Boston. And this is a patient who had 2-level adjacent segment disease. She has a lot of osteoporosis. She's bone on bone. So instead of taking the hardware out and so on, I went from the front. Her bone is very soft, so we put cement, we put screws in the front, we lifted up the spine, all through one small incision, like as you see the hardware in the back, and that's the patient right here. So we saved that patient the open surgery in the back, taking the hardware out, and exchanging the screws and the system. How about MIS? Now, when you get we start doing MIS surgeries in simple cases, you get more complex cases for you. And here's patients came to me from I believe Qatar. This patient had a prior surgery, L3 to L5. The patient has pseudoarthrosis. Those that were not fused. So she broke down above and broke down below the fusion. And look at the aorta, how it's calcified. So we do the same principle. We go from the side. While the patient on her side, Ajamba, we go through this 1 centimeter incision in the back. I loosen up the screws in the back. Now my spine is as a virgin back. The screws and rods are loosened up. Do the cages in the front. And I put my cage in the front, and I flip the patient on her back. Now she goes down prone. It's not advancing. X-ray, it's not advancing. ما عم بقدر اقرب السلايدز. Oh, something happened. Okay. So this is a patient here. We go posteriorly, and then we do the percutaneously from the back. It's okay. Sorry, it's just this patient with infection. Of course, with the infection, you wonder, should I put instrumentation, should I not put instrumentation, so on. So what I do is, this is to treat this patient. I put the instrumentation and the vertebra above, vertebra below. This is the infection here, as you can see. And once the infection is healed up, after the breed one, I take the hardware out. This is the small incision that you see in the back. And then take the hardware out, and the patient left with no fusion in her back, except for the infected level. Trauma, the same thing. You put the screws in. When the fracture heals, you take them out. And then now the patient is left with no fusion from a trauma. So I'll finish with one slide. So what happened with the fragility fractures? This is a major problem for all of us. We all have it in our practice. Multiple patients with osteoporosis, fracture after fracture after fracture after fracture. And If you want to fix that, whatever fixation for that segment is going to break above it and below it. The same thing with metastases. You treat, certain vertebrae, and then 6 months later, 3 months later, there's a new metastasis going up and down. So we develop a technique we call infix, which meaning we stabilize the spine as a supporting rod and up and down, and this is published as well. So this is a patient came to us with multiple fractures. You can see every vertebra is fractured in her back. She couldn't sit up, so we did this what we call the infix concept, meaning putting the rod in to support. And you have a building عندكم بناية راح تقشط راح تهر. And you support it from outside and then before it collapses. So this patient, that's exactly what we did. And this is the patient right there. And you can see the patient is already up. She could not stand up for 3 months, before that. This patient with multiple level metastases, cancer, and the same thing. So we treated this, for infix concept. We put the rods, and then let the rods support the spine, and they support each other. So is it worth it? I will leave it up to you and to your practice to make that judgment. And it's all what I can say, that MIS is not the same procedure through small incisions, and MIS should not be open procedure via small incision. It's simply a better procedure. Thank you so much.